So this lecture component is going to look at treating opioid overdoses, and there's two drugs that we should be familiar with. One is naloxone, which is given IV. This is going to offer immediate reversal of opioids' CNS effects, and what will happen is that this drug will antagonize the opioid receptors, and it will compete with other opioids for those receptors. The half-life is short, 1 to 2 hours. In contrast, naltrexone, which is given IV, is very similar to naloxone. Obviously, this drug is effective orally, and it's got a much longer half-life, anywhere from 10 to 12 hours, depending on who you read. In terms of opioid abuse or opioid use disorders, the diagnostic criteria are listed here. And of course, Dr. Dance will go into much more detail about these criteria and spend a little bit more time discussing some of these nuances. But these are kind of the hallmarks of this disorder. Other treatment strategies include methadone, which is an orally active opioid receptor agonist. The duration of activity is longer than heroin, and it's been used for heroin detox programs. Buprenorphine is a partial mu opioid receptor agonist and can be used for similar reasons. Because it's got both partial mu agonist activity and full kappa receptor antagonist activity, there's limited effects, and it actually offers kind of a more comfortable withdrawal according to these patients. Naltrexone is another opioid agonist that's useful to prevent relapses. It will block the effects of opioids, but in some patients it may actually precipitate a withdrawal, so you have to be careful. Typically, we only use naltrexone after the patient goes through a withdrawal symptom because we don't want to actually have them go through another withdrawal. Naloxone is not used in the treatment since it's not orally active. It's used in overdose treatment, and so it's also of short duration, so just kind of keep that in mind. And so kind of first-line therapy, we're looking at buprenorphine, of course, which is safer than methadone, followed by methadone because it requires a clinical-based treatment and a little bit closer monitoring. Second-line therapies include naltrexone. These can be reasonable first-line treatment in really highly motivated patients, and I'm sure Dr. Dance will talk to you about the motivation of some of these patients to get off of some of these drugs. Of course, there are special instances, some of which are summarized there. So these are the main points for opioid pharmacology. And if there's any questions, please email us. Thank you.